Welcome back to the deep dive. We're here to sift through the complex source material and basically give you the crucial insights without the heavy lifting.
And today we're tackling a really vital area, the thoracic cavity. Think of it as the body's central vault for life support.
Absolutely. Our mission today is to connect the dots, right?
Yeah.
Between the basic anatomy,
Hmm.
the mediastinum, pleurae, lungs, heart, the vessels, and those really dramatic clinical situations that hinge on this structure.
Exactly. Because understanding the structure helps make sense of the symptoms. And where better to start than with chest pain? It's the number one reason people hit the emergency room, often terrified.
It demands immediate answers. Is it muscle strain or something far worse?
Precisely. So we'll kick off with a case that really highlights how anatomy dictates pathology, a pretty severe one.
Okay, let's get into it. We've got a scenario here based on the sources. A 54-year-old patient comes in. They're describing this just excruciating pain, knife-like, they say. Starts in the front of the chest.
Mhm.
But then it radiates down the arms, up into the neck, and even pierces right through to the back, between the shoulder blades. That just screams emergency, doesn't it?
Oh, absolutely. That pattern, especially the radiating part and the intensity, coupled with a specific finding on exam, that sets off major alarm bells.
And what was that finding?
The sources note a really significant difference in blood pressure between the arms. It was high, like 200 over 110 in the right arm,
Okay.
but quite a bit lower in the left arm. That asymmetry is, well, it's a textbook red flag for an aortic dissection.
A tear inside the wall of the aorta, the main artery leaving the heart. Life-threatening stuff.
But hang on, why the left arm pressure drops specifically? Is the aorta completely blocked?
Not usually completely blocked. No, it's more mechanical. You see, the tear creates this sort of flap within the aortic wall.
Okay.
And in this case, described in the source material, that flap was positioned just right, or rather just wrong, to partially obstruct the opening of the left subclavian artery.
Ah, the arteries supplying the left arm. So the flow gets pinched off downstream. Exactly. Less flow, lower pressure. The anatomy directly creates that measurable sign. Simple mechanics, really, but with devastating consequences.
Right. And this brings us to that whole concept of referred pain. It can be quite confusing. The aorta is deep inside the chest, so why does the pain feel like it's crushing your arm or jaw?
Yeah, it's a classic case of crossed wires, basically. The pain signals from the damaged aorta travel back to the spinal cord via sympathetic nerves.
Okay.
But here's the cue. They enter the spinal cord at the same levels as the somatic nerves, the ones that carry sensation from the skin of your chest, your arms, your neck.
So the brain gets this intense pain signal coming from, say, spinal segment T2.
Right. And the brain, which mostly deals with signals from the skin via the somatic nerves, just assumes the signal must be coming from the skin area supplied by T2. It misinterprets the origin.
It attributes the deep visceral pain to the surface area it knows best.
Precisely. That's why aortic dissection pain radiates like that. And it's the same principle behind the arm and jaw pain in a heart attack, which we'll touch on later. Understanding this wiring is crucial for chest pathologies.
It really highlights the interconnectedness. Now, this whole drama plays out within the thoracic cavity. Structurally, you mentioned it's divided.
Okay.
We have the central mediastinum
Yep, the core compartment. It holds the heart, the great vessels like the aorta and vena cava, the trachea, the esophagus, basically the main transit zone.
and flanking that.
Two pleural cavities, one for each lung, and a key landmark mentioned in the sources separating the upper superior and lower inferior parts of the mediastinum is the sternal angle. That lines up with the T4 vertebra level.
Got it. T4. So let's talk about this central mediastinum first. It sounds protective, housing all those vital organs.
It is, but its structure also presents a vulnerability. The organs aren't rigidly fixed. They're embedded in loose connective tissue.
Loose tissue. What's the clinical downside of that?
Speed of infection. If something perforates in there, like the esophagus, bacteria can spread incredibly fast through that loose tissue. It can lead to mediastinitis, a really severe, widespread infection throughout the chest, potentially fatal. So the flexibility it allows comes at a price if barriers are breached.
That really puts things in perspective.
Yeah,
Okay, so moving outwards from that central zone to the pleural cavities lining the lungs. There are two layers there, right? And they differ in sensitivity.
exactly. You've got the parietal pleura, which lines the inside of the chest wall. Think of it as the wallpaper. It's served by somatic nerves, like the intercostal and phrenic nerve, so it's very sensitive to pain, temperature, touch.
Okay, sensitive wallpaper.
Right. Then you have the visceral pleura, which directly covers the lung surface itself, like shrink wrap on the lung. This layer is insensitive to pain, stretch, temperature.
So inflammation of the lung itself might not hurt.
Yeah.
But if that inflammation reaches the parietal pleura,
Then you feel it. Sharp pain, often worse with breathing. That's pleurisy. And clinicians can sometimes even hear a rough scratching sound with a stethoscope, a pleural rub from those inflamed layers grinding against each other.
wow. And this space between the layers, the pleural space, it's normally tiny, right? Just a few milliliters of fluid.
Normally, yes, just 5 to 10 milliliters for lubrication. But it can fill up dangerously. If air gets in, say from a lung injury or a chest wall puncture, that's a pneumothorax.
The lung collapses because the negative pressure holding it open is lost.
Correct. But the really critical emergency is a tension pneumothorax.
Why is that one so much worse?
Because the air gets in, but it can't get out. It acts like a one-way valve. Pressure builds and builds inside the affected chest cavity.
And that pressure does what?
It pushes everything. It physically shoves the entire mediastinum, the heart, the trachea, the great vessels, over to the opposite, healthy side.
Oh.
That deviation kinks the great veins, stopping blood from returning to the heart. The patient becomes severely breathless, blood pressure plummets at circulatory shock. A true mechanical emergency caused by trapped air.
Just staggering. All that from air in a potential space. Okay, let's follow the air path inwards now. The trachea, the windpipe comes down and splits. Where does that happen?
Right around that same landmark we mentioned, the sternal angle, T4 level. It bifurcates, splits into the left and right main or principal bronchi.
And there's a key structural difference here, isn't there? Something clinically vital, especially with kids.
Hugely important. The source material points this out clearly. The right main bronchus is different from the left. It's wider, it's shorter, and crucially, it runs more vertically. It's almost a straight shot down from the trachea.
Whereas the left one branches off at more of an angle.
Exactly. Which means if someone inhales a foreign object, the classic peanut, a small toy part, a bead, even a pin.
It's more likely to go right.
Overwhelmingly so, yes. It tends to follow the path of least resistance, straight down the wider, more direct right main bronchus. And often, it ends up lodging specifically in the right inferior lobar bronchus.
So if a child comes in after potentially aspirating something, to focus your search on the right lung first.
Absolutely. Saves critical time. It's pure anatomical probability.
That structural logic extends deeper too, right? Into the bronchopulmonary segments. The sources call them pyramid-shaped independent units.
That's right. Each lung lobe is further divided into these segments. Think of them as self-contained functional units. Each one gets its air supply from its own segmental bronchus and its blood supply from its own branch of the pulmonary artery.
And the clinical relevance there is surgery.
Precisely. Because they're structurally and functionally independent, a surgeon can, in many cases, remove just a single disease segment, maybe one affected by cancer or a chronic infection, without disrupting the neighboring healthy segments.
A segmentectomy.
Exactly. It preserves lung function compared to removing a whole lobe or lung. You can remove the diseased part while minimizing bleeding or air leaks from the adjacent healthy tissue because you're respecting those anatomical boundaries.
Neat. Okay, so we know how air gets distributed. What about just the basic mechanics? Getting air in and out quietly, how does that work?
Well, quiet breathing in, inspiration, is an active process. The main muscle is the diaphragm. It contracts and flattens, moving downwards, increasing the vertical space in the chest.
Okay.
And the rib cage also expands. The ribs move outwards and upwards, kind of like a bucket handle lifting, which increases the side-to-side and front-to-back dimensions.
So you make the box bigger.
Volume increases, pressure inside drops below atmospheric pressure, and air naturally flows in. Simple physics.
And breathing out. Quiet expiration.
That's typically passive. The muscles relax, and the natural elastic recoil of the lungs and the chest wall causes the thoracic cavity to shrink back down, increasing the pressure and pushing air out. No active muscle contraction needed for quiet outflow.
But what about when you need to breathe out forcefully? Like coughing or during heavy exercise? They can't just be recoil.
No, you're right. Forced expiration is very much an active process. It recruits powerful muscles, particularly the abdominal muscles.
Your core muscles.
Yeah.
The rectus abdominis.
Exactly. They contract forcefully, pulling the rib cage down and inwards, and also pushing the abdominal organs upwards against the diaphragm.
Squeezing the thoracic cavity from below and around.
Right. This rapidly decreases the thoracic volume much more than simple recoil, powerfully expelling air. So the body shifts from passive efficiency for quiet breathing to active force when needed.
Makes sense. Okay, we've got the airways, the mechanics, but it's all to serve the engine in the middle. Let's shift focus to the heart, sitting there in the mediastinum.
The central pump, or really two pumps in one package. The right side of the heart handles the pulmonary circuit, sending blood to the lungs. That's a low-pressure, low-resistance system.
And the left side?
That's the systemic circuit pump, sending oxygenated blood out to the entire body. It faces much higher resistance, which is why the left ventricle wall is significantly thicker and more muscular than the right.
4 chambers total, 2 atria receiving blood, 2 ventricles pumping it out. But what controls the rhythm? It's not just mechanical.
No, it has its own internal electrical system, the intrinsic conducting system. Specialized cardiac muscle cells that generate and conduct electrical impulses.
Starting with the pacemaker.
Right, the sinuatral node, or SA node. It's high up in the right atrium. It spontaneously generates electrical impulses at about, 70 to 90 beats per minute, setting the basic heart rate.
And that signal spreads?
It spreads through the atria, causing them to contract, then gets funneled through the atrioventricular node, AV node, and down the bundle of His, which connects the atria to the ventricles, ensuring a coordinated contraction sequence. Atria first, then ventricles.
It's a finely tuned electrical sequence. But the sources mention something really startling about its vulnerability, commotio cordis.
Ah, yes. It's chilling. It means sudden cardiac death caused by a blunt impact to the chest wall, no penetrating injury, just a blow.
How does a simple blow cause cardiac arrest?
It's all about timing. The impact itself isn't necessarily massive, but it has to land on the chest directly over the heart during a very specific, very brief window in the cardiac electrical cycle.
Which window is that?
It's during the repolarization phase, specifically the upstroke of the T wave you'd see on an EKG. We're talking a window of maybe only 10 to 30 milliseconds.
Tiny window.
Extremely brief. But if a blow lands precisely then, it can scramble the heart's electrical activity, throwing it into ventricular fibrillation, a chaotic, ineffective quivering, which is fatal unless corrected immediately.
And this happens more in young people, like in sports.
Yes, often in sports like baseball or hockey where a projectile hits the chest, younger people tend to have more compliant, less rigid chest walls, which might transmit the force more directly to the heart. It's a terrifying combination of anatomy, physics, and precise, unlucky timing.
Unbelievable. Now, speaking of the heart's neighbors, you mentioned the esophagus runs right behind it.
Very closely behind, yes. Particularly the back wall of the left atrium rests almost directly against the front wall of the esophagus.
And that proximity is clinically useful.
Absolutely. It provides an indirect way to assess the heart. Imagine a patient has left-sided heart failure. The pressure backs up, and the left atrium can distend quite significantly.
Okay.
As it enlarges, it physically pushes backwards on the esophagus.
Ah, I see where this is going.
Right. So a clinician can have the patient swallow barium, a contrast agent that shows up on X-ray. As the barium goes down the esophagus, you can see if it's being indented or displaced by an enlarged left atrium behind it.
So you can infer the size of the left atrium by looking at how it affects the esophagus on a barium swallow X-ray.
Clever. It's a classic diagnostic link based purely on that close anatomical relationship.
Okay, let's connect back to pain again, but this time related to the heart's own blood supply, the coronary arteries. The sources call them functional end arteries. What does that mean?
It means that although there might be tiny connections between different branches, they generally don't provide enough collateral circulation to compensate if a major artery gets blocked suddenly. Each main coronary artery branch effectively supplies its own territory of heart muscle, without a significant backup plan.
So if one gets blocked by a clot, say an acute thrombosis,
Then the heart muscle supplied by that artery is starved of oxygen. That's ischemia. If it lasts long enough, the muscle tissue dies. That's a myocardial infarction, a heart attack. There's little redundancy in the system.
no plan B. And the pain from that ischemia, we're back to referred pain again.
Exactly. The pain signals from the oxygen-deprived heart muscle travel back via those same sympathetic afferent fibers we discussed with the aorta.
And they enter the spinal cord at the same levels as nerves from the chest and arm.
Correct. Primarily the upper thoracic segments. So again, the brain misinterprets the visceral signal as coming from the somatic areas typically felt as that crushing central chest pain, which often radiates, classically to the inner side of the left arm, sometimes the neck or jaw. It's that same neural pathway confusion.
The whole cavity just seems intricately wired and structurally interconnected. We've seen how the mediastinum's loose tissue aids infection spread, how the bronchial asymmetry directs foreign objects.
It really drives home how critical structure is. Structure dictates function, and it also dictates how things go wrong, the pathology. And, we've mostly talked about diseases people acquire.
Right, like dissections, infections, heart attacks.
But it's worth remembering, as the sources point out, that the very foundation, the development of these structures in the embryo, isn't foolproof either.
You mean congenital problems, things people are born with.
Exactly. The sources mention serious conditions like tetralogy of Fallot, that's a complex set of 4 heart defects present at birth. Or even simpler things like atrial septal defects, holes between the atria.
Holes in the heart wall.
And interestingly, one type of small atrial defect called probe patency, basically a tiny potential opening that didn't fully fuse shut, actually persists in about 20–25% of perfectly healthy adults.
A quarter of us might have this tiny remnant.
Roughly, yes. It usually causes no problems, but it's a fascinating reminder that the complex developmental process that builds this vital structure we rely on every second isn't always absolutely perfect. There can be minor or sometimes major flaws right from the start.
That really sets up a final thought for you, the listener, doesn't it? We've explored how these developed structures, the plumbing, the wiring, the mechanics of the thorax can fail in dramatic ways.
Yeah.
But what about the very beginning? What are the intricate signals and mechanisms that normally ensure that 4-chambered heart, those great vessels, and the airways all form correctly during embryonic development in the first place? That's perhaps a deep dive for another time.